The next lecturer will be Professor Marty Leon, a close friend. Marty, aside being one of the most famous interventional cardiologists in the world, is a professor of medicine at Columbia University College of Physicians and Surgeons. He is the director of Centers for Interventional and Vascular Therapy at the New York Columbia University Medical Center, the director of Cardiac Catheterization Laboratories in New York, and the executive board of director of the New York Columbia Valve Centers. As you will see, he's a real old friend, and this is the first party of the Palma shots coming in. But Marty actually was the founder and director of the TCT meeting starting 25 years ago, and this year we're going to celebrate 25 years anniversary. He's the founder and chairman of the CRF, founder at Washington University Center, previous director of the Cardiovascular Research Center. And Marty is a dear friend, and that's what counts. And I'd like to invite Marty to a lecture that we entitled From PTCA to TAVR, Have We Fulfilled Wunsic Dream? Marty, it's our pleasure.
Thank you very much. It certainly is a pleasure to be here. I have to congratulate Chaim Latan, my good friend, and doctors Sahar, Segev, and Fink, and the executive committee who have established an extraordinary 60th anniversary program for the Israel Heart Society. So it really is a privilege to share some of my experiences with you. But it's also an interesting anniversary for me. This is not just the 25th year of TCT, but it's the 25th anniversary of my first trip to Israel. And I had the opportunity with Yaron Almagor and other physicians to go from hospital to hospital and to help implant some of the first balloon expandable stents in patients with coronary disease. And over the past 25 years, I've now had 50 trips to Israel. And I really believe that my professional identity is inexorably linked to my participation in Israeli cardiovascular medicine. So it really is a special honor to be here. It also is a dubious distinction to follow Eugene Braunwald, who is an iconic figure, not just in cardiology, but in global medicine, and to be the last obstacle before lunch. So my disclosures. You've seen many pioneers in cardiology. I'll show you some of the early pioneers in what we now call interventional cardiology. Of course, Werner Forssmann, Mason Soames, Charles Dotter, leading up to Andreas Grunzig. This was the tool that Andreas Grunzig used. This is a balloon catheter, a fixed wire balloon catheter. He used a technique of mechanical barotrauma to displace coronary atherosclerosis, a technique we later called PTCA. You see him in the catheterization laboratory. And now you see his first patient, treated September 19th, 1977, Dolph Bachmann, a proximal LAD after a single inflation in the LAD, a remarkable result. Unfortunately, not all the results were quite as remarkable. But his dream, as the founder of PTCA, was that catheter-based percutaneous treatment of vascular disease could be accomplished in alert, awake patients. But after having an opportunity to get to know Andreas Grunzig and to understand his motivations, he had several principles, many of which are not well understood. He desperately wanted this technique to be safe, to minimize major complications, including things like abrupt closure that needed surgical backup. He wanted the technique to be predictable, that we would have consistent procedural results in all lesions treated and in all patients. He desperately wanted it to be appropriately applied, only to treat clinically significant lesions. And I was at the NIH in the first procedures that were done in the late 70s with balloon angioplasty, And following Grunzig, we would measure translesion gradients to make sure that there was a hemodynamically important lesion. And he was very conservative, and he conservatively expanded angioplasty from simple to more complex lesion subsets. He was concerned about definitive outcomes. He wanted to find better ways to optimize acute angiographic results, and he was certainly appalled by the concept of restenosis. He believed in evidence-based medicine, although we didn't call it that at the time. He was committed to rigorous clinical research to identify complications and justify appropriate clinical applications. In fact, he was one of the major contributors of the original NHLBI PTCA registry. He cared about technology innovation, the relentless effort to improve all aspects of interventional device technology, including angiographic imaging and the cath lab milieu and staffing. And he had a multidisciplinary approach. In fact, he started as an angiologist doing peripheral angioplasty using the Dotter technique. So he felt you needed to apply the principle of less invasive catheter-based treatment of remote lesions across different vascular beds, and that could be by different subspecialty therapists. So the training and commitment was what was important, and that really overrides territorial specialist considerations. So these were his principles, and it's my charge to see if we've been able to fulfill those principles over the subsequent 35 years since that original PTCA. So let's start by talking a little bit about balloon angioplasty and early stents. I can summarize balloon angioplasty in this slide. We had frequent dissections, recoil, poor angiographic outcomes, this entity of acute closure, which did require surgical backup. It was ineffective in many lesion subsets, including calcified lesions. And if we were to be honest with ourselves, restenosis occurred very frequently in as many as 30 to 50% of patients. In fact, in this austere medical journal, you see here Men's Health, somewhere between How to Lose Your Belly and the Great Condom Test, was an article called A Balloon Goes Bust. And basically what it said was that if you only had balloon angioplasty as the treatment of patients with coronary atherosclerosis, then frankly, I don't know if we would have the field of interventional cardiology 35 years later. It was simply not good enough. So after Grunzig died, many people began to see how they could improve the balloon angioplasty technique, and he died again, much too young, in his mid-40s in 1985. There was an interesting period of new device treatment of patients with coronary disease. We used laser angioplasty, atherectomy, directional, rotational extraction, in the very early days of stents. This is a laser hot tip catheter, and this is an advertisement in a medical journal. You've never used a catheter like this before. Well, when I was at the NIH, I had the opportunity to use this in patients with peripheral vascular disease, and once you did, you would never want to use it again. We worked with various forms of coronary atherectomy, extraction, directional atherectomy, rotational atherectomy, most of which were relatively unsuccessful. I can summarize this interesting period of trying to apply new devices to treat patients with coronary lesions as saying we saw frequent complications and some new ones like perforations. We did have some improvement in complex lesion subsets, particularly calcified lesions. But this required much greater operator expertise, was more costly, and the restenosis rates were even higher. So no, this era was not particularly successful. It was still not good enough to jettison interventional cardiology into the mainstream of cardiovascular therapeutics that could contribute to the armamentarium of devices and techniques to treat patients with obstructive coronary disease. But we did have an opportunity to work with this interesting device. This is a slotted tubular stent. It's 15 milligrams of 316L stainless steel, originally devised by Julio Palmaz, later the contribution of Richard Schatz. I worked with Julio Palmaz in the animal laboratories in the mid-80s at the NIH to study the vascular responses to a device like this. This is what it looks like when it's implanted into a coronary artery. And these were the early days of coronary stents. It was a very exciting time to be able to actually put a device in the coronaries that would achieve a predictable outcome. The first patient was treated with a balloon expandable stent in Sao Paulo, Brazil, December 31st, 1987. A year before we came to Israel to start implanting them here. And this was the beginning of randomized trials in interventional cardiology. This is Benestent 1, a study that was done in Europe led by Patrick Sarais, comparing bare metal stents versus balloon angioplasty, showing a reduction in restenosis and a very interesting effort to try to quantitate coronary angiography using important new techniques. We did a parallel study in the United States called STRESS, STRESS 1, STRESS 2. Again, a 600-patient randomized trial looking at elective stenting versus balloon angioplasty, again showing benefit, but frankly, the benefit was not so striking in terms of reducing restenosis, but we did improve the safety and the predictability of balloon angioplasty. And after 6 agonizing years of clinical studies, we finally had approval of this device in the United States, and we were off and running, and the mantra of how to treat patients with coronary disease was to use stents, use them frequently, and in fact, in retrospect, too frequently. I would describe this as the age of empiricism. It was the early days of balloon PTCA through this new device era, where the determination of clinical value was assessed via case experiences, by word of mouth, and by non-rigorous observational studies. This was a pseudo-surgical approach. It was a surgeon seeing a case and describing it to other surgeons, which really disseminated technique. It resulted, unfortunately, in an overly simplistic and often incorrect impression of many interventional device therapies. But the FDA approval of the Palmaz-Schatz coronary stent in 1994, which was based upon the earliest randomized controlled trials, Benestent and STRESS, ushered a new era of evidence-based medicine in interventional cardiology. And that led to the next step, which is the DES era. Now, as I said, bare metal stents helped. They helped to improve the predictability and the safety of angioplasty, but they also induced a vascular response, which resulted in proliferative neointimal hyperplasia, a monomorphic response, which would cause in many patients significant restenosis. So this was unacceptable. So new devices were developed, and to develop a drug-eluting stent was truly an advanced biotechnology platform. To be able to combine a bare metal stent with a drug carrier that would incorporate a pharmacologic agent that would have specific local effects on the vascular wall and elute over a period of time to achieve a specific biologic response was unheard of at the time. We did animal studies in the mid-1990s to demonstrate these various devices seemed to be safe and seemed to be effective in animal models of restenosis. And the first generation drug-eluting stents were introduced, the so-called Cypher and Taxus stents with different drugs, different polymers, different stent backbones, but somewhat similar effects. And then applying these in patients, the results were striking. This is the first patient that was treated, and you can see this is a diabetic, an LAD, relatively diffuse lesion, treated with a single stent. Now 4 years later, an identical response. So Patrick Sarais issued his rosy prophecy that restenosis was cured. Well, life and human biology is not so simple. It wasn't cured, but there was tremendous excitement at the time of follow-up studies, and the first 30 patients showed no restenosis, which was, of course, very exciting. We did many studies in the United States. We published this meta-analysis in the New England Journal of Medicine of 9 prospective double-blind randomized trials looking at freedom from ischemic TLR, and you can see a dramatic effect on reducing restenosis. So undoubtedly, these new devices certainly had an important effect on reducing restenosis, and that was significant because the idea of patients having to come back for repeat procedures is certainly, it may be an annuity for some cardiologists, but certainly was very disappointing for thoughtful physicians everywhere. So these were the early days of drug-eluting stents, where perhaps belief, hope, and hyperbole really exceeded some of the clinical evidence. and there was over-exuberant use of drug-eluting stents. We felt that it solved restenosis, the pivotal data looked terrific, and maybe they're good in all lesion types and in all patients, and the penetration of this technology in patients treated with interventional techniques in the United States approached and exceeded 90% over a very short period of time. Then, very interestingly, now 5 years later, after the first implantation of a drug-eluting stent, first implantation was December of 1999. Here in a short manuscript in The Lancet in 2004, 4 episodes of late drug-eluting stent thrombosis after discontinuation of antiplatelet therapy. And then there were a rash of reports. This is several interesting studies, the Bern-Rotterdam experience, the pooled analysis from the Cypher and Taxis trials, each indicating that there was a higher frequency of late stent thrombosis associated with these devices. So suddenly again we realized that no, nothing is perfect, and that by suppressing neointimal growth we also impaired healing, and in doing so we created a thrombogenic milieu which at times could be pathobiologic and deleterious and induce this response of very late stent thrombosis. In addition, there were hypersensitivity responses. There were episodes of incomplete apposition and positive late remodeling. There was abnormal vasomotion. So these new advanced biotechnology platforms, the original first generation ones, were by no means perfect. And in fact, at a meeting at ESC in August of 2006, that we now call the ESC Firestorm, there was a declaration that drug-eluting stents were killing patients based upon an analysis of some randomized data that had not been published yet, but certainly this created a furor within not just the interventional, but the medical cardiology community as well, and of course the lay press being very eager to publicize a new story, characterized drug-eluting stents as a million ticking time bombs. So these were the dark days of drug-eluting stents, where fear-based avoidance and perhaps some distortions actually exceeded the true evidence. And there was a dramatic drop in the frequency of using drug-eluting stents everywhere, including the United States, where drug-eluting stents were thought to be associated with increased thrombosis and increased mortality. At the same time, the COURAGE data was introduced, challenging whether intervention at all was necessary in patients who had elective treatment for coronary disease, and medical therapy may be sufficient. So people felt that maybe drug-eluting stents should be dramatically reduced. It was interesting to feel the response at that time, because it was a mobilization of the entire global community that was involved not just in interventional cardiology, but cardiovascular medicine. And there was a true explosion of evidence-based medicine data, over 2,500 peer-reviewed manuscripts on drug-eluting stent clinical use in a 10-year period between 2002 and 2012. One of those studies was a meta-analysis that we did, published in Circulation in 2009, trying to resolve this issue, whether or not DES were actually associated with an increase in mortality. This is a meta-analysis involving almost 200,000 patients, an analysis of over 800 clinical trials that was done by our clinical trialists, who, by the way, trained at Harvard. And we found that no, we couldn't find any association with late mortality or with myocardial infarction, either in the randomized trials or the observational registries. In fact, we saw a reduction in mortality and myocardial infarction compared to bare metal stents. So I think there may have been some exaggeration and distortion, but certainly late stent thrombosis was a concern. Perhaps some of the second generation drug-eluting stents that we're now using, different drugs, different polymers, studied much more carefully, perhaps more appropriate to the specific application of treating the vascular bed with drugs at proper doses, with agents that did not induce inflammation, induced better responses. So there's been a slow return of drug-eluting stents, which is now relying on overwhelming evidence, where the penetration rate has increased, not to where it was, and frankly it never should have been that high. And I believe that there is good evidence to suggest that PCI is better for symptom relief and reducing ischemia than medical therapy, that DES don't increase mortality or MI, and they do reduce target vessel revascularization rates dramatically, and there's more confident DES use with the current generation, but with careful attention to the adjunctive pharmacotherapy, particularly dual antiplatelet therapy, and there'll be many more developments along these lines. But this has been the evolution from the age of empiricism to evidence-based medicine. And this transition, I think, has distinguished interventional cardiology as a modern subspecialty, committed to scientific principles and the highest ethical standards of conduct. Undoubtedly, now and in the future, all new important therapies will require evidence-based medicine validation in the form of well-conducted clinical trials. But I'll tell you, evidence-based medicine is not perfect. And if the data are not interpreted in a balanced fashion, evidence-based medicine can result in more confusion than clarification. And there are other factors beyond evidence-based medicine where you must also heavily rely on in making clinical decisions, like clinical judgment and experience and patient expectations that need to be factored in on a case basis in terms of trying to decide the best therapy for your patients. So how do we transition from the Grunzig era of coronary and vascular intervention to something like transcatheter aortic valves? Well, the reality is the COURAGE trial, an important study, demonstrated that certainly we need to pay much more attention to optimal medical therapy in all of our patients with coronary disease. The 5-year follow-up from the SYNTAX trial indicates that clearly in patients with the most complex forms of coronary disease, complex multivessel disease, that there are some advantages of surgical revascularization compared to aggressive angioplasty, even with drug-eluting stents. Recently, the FREEDOM trial indicated that in diabetic patients, again with complex multivessel coronary disease, that there may be some advantages of bypass surgery versus drug-eluting stents and angioplasty of any kind, and we must consider all these things. We also must consider, in this study that was published a few years ago, the FAME trial, that we have to be treating the right patients and the right lesions. And this is coming full circle. This is using invasive physiology to measure and document ischemia for a given lesion, and then only treating those lesions which are significant. And there was a dramatic impact on clinical outcomes by using not more but less stents, but using them in the right circumstances. So with all of these forces, it's certainly not surprising that there would be a cry for appropriate use for coronary revascularization, and we're trying to make the right decisions of how to treat patients with coronary and other forms of vascular disease, and to take into account some of the lessons we've learned from these important clinical trials. But in doing so, I can tell you that certainly in the United States, and I would guess in Israel, and in most other developed countries that practice interventional cardiology, if you look over the next decade, you will not see a further growth in the number of patients that have PCI. That the PCI activities will be relatively stable or flat, maybe even some decline. In fact, in the US, there's been a 15% decline over the past 5 years. And I would endorse the idea of the selective and appropriate treatment, endorse that very strongly. But if you look at the projections of where interventional cardiovascular medicine is going, there's an expected doubling of the not just economic potential of this market, but of the treatment segment that we're going to be focusing on. And that's where the transition comes from the earlier Grunzig principles. If we look at other procedures like transcatheter aortic or mitral valve treatment, left atrial appendage closure, renal denervation for hypertension, and maybe for many other things that have sympathetic overdrive syndromes, and other techniques that we don't have time to even discuss, there is a dramatic potential to see an increase in interventional cardiovascular therapy, but it won't be coronary angioplasty. One of the examples is what we're now calling structural heart disease. This is really a wastebasket term that applies to all catheter-based interventional therapies that are not associated with vascular pathology requiring endoluminal endovascular treatment. So it's the transcatheter valve therapies, left atrial appendage closure, adult congenital heart syndromes, as I've mentioned, renal denervation, heart failure and advanced hemodynamic support, and many other out-of-the-box concepts that span the gamut from impotence to obesity to multiple sclerosis. And it's using the same principles. But as a case in point, let me spend just a few moments talking about the aortic valve and transcatheter aortic valve replacement, which is something that I became very familiar with. When I was at the NIH, I was involved in some of the natural history studies, looking at patients with aortic regurgitation, aortic stenosis. I did a lot of those 6-month catheterizations that Dr. Brownwell was talking about following the patients who had cardiac surgery. As you see here, the natural history of untreated aortic stenosis that Dr. Brownwell beautifully described. But the problem now is, this is the patient population that we're facing. The latency period is long. When they finally present with symptoms, they're often far more elderly, and they've accumulated multiple comorbidities, and they're simply not as good patients for open surgical valve replacement. In fact, in these 7 studies over the past 10 years, at the very minimum, 30% of patients with severe symptomatic aortic stenosis are not receiving surgical aortic valve replacement, and this became the target of a newer, less invasive catheter-based technique. The reasons, of course, the patients were too old, they had comorbidities, or the patients simply refused to go through what would be a significant operation in an elderly comorbid state. I have to credit my colleague Alain Crebier for his relentless pursuit of this field, beginning with balloon aortic valvuloplasty in the mid-1980s, and the work that he did to try to help develop new therapies for patients that had end-stage aortic valve disease. We formed an entity, which was an Israeli company called Percutaneous Valve Technology. Some of the people are in this room. We fumbled a bit in the beginning. We started with polyurethane valves. We ultimately bovine pericardial valves that were sewed to a support frame that looks very much like a stent, that was crimped onto a catheter. And this is the first case that was done. It was done more than 10 years ago, April 16th, 2002, in a man who had end-stage aortic valve disease in cardiogenic shock, who was refused for surgery with a previous pneumonectomy and ischemic vascular disease of his lower extremities, pancreatitis, simply could not be treated any other way. And it was a shockingly successful proof of concept single case, and we published this in Circulation. And Alain Crebier, in his typically understated way, said that non-surgical implantation of a prosthetic heart valve can be successfully achieved with immediate and midterm hemodynamic and clinical improvement. And I must say, we had no idea if this technique could be generalizable, could it be safe, what would be the durability of it. This was simply a first case proof of concept. Well, these 2 devices, one balloon expandable, one self-expanding, have now been used in over 75,000 patients in over 750 interventional centers around the world over the past 6 years. And Israel is one of the leading countries in per capita use of transcatheter aortic valve therapy in patients with severe symptomatic aortic stenosis. Getting back to Grunzig's principles, the idea of a multidisciplinary collaboration, this is the paradigm of how we treat patients with complex cardiovascular disease. You develop heart teams. You don't work in a competitive, antagonistic way with your cardiac surgeons. You embrace them as colleagues, and you treat patients the way they should be, as being the recipients of the best care by the best physicians who are committed and trained in a particular disease state. And this is the team we've assembled at Columbia. We became interested in adjunctive imaging, and this is a great example of how we use new imaging techniques for screening, guidance, and follow-up. And it's not just angiography anymore. It's CT, and it's echo, and it's transesophageal echo, and it's 3D echo, which are absolutely necessary to treat these complex patients. We've had to develop new milieux. This happens to be one of the dedicated hybrid cath lab ORs, which is extremely important, at least for us, to be able to apply some of these complex therapies in patients with end-stage disease. And we were committed to evidence-based medicine and did what is perhaps one of the more important randomized trials in valvular heart disease over the past several decades, and one of the largest studies ever done in aortic stenosis. It was called the PARTNER trial. We began in 2007. We screened 3,100 patients to randomize slightly over 1,000 in 2 parallel arms, both randomized, patients that the surgeons considered to be inoperable, that were randomized either to this new therapy, transcatheter technique, or what was the standard therapy for these patients who could not have surgery, and then another cohort of almost 700 patients that were high risk, the highest decile of risk, and those patients were randomized to either surgery or to transcatheter aortic valve replacement with a fairly early stage device, frankly. So who were we treating? Well, these were the kinds of patients we were treating. They were all very old, frail, they had many comorbidities, but still enjoying life. And let me tell you, I've got a new appreciation for the elderly, the mean age of the patients in this study was 84. 20% were nonagenarians. And it's shocking to see the quality of their life improved over a very short period of time by replacing the aortic valve. Suddenly, interventionalists felt a little bit more like surgeons. We had the opportunity to publish 4 manuscripts over an 18-month period in the New England Journal of Medicine from this single clinical trial to attest to the effort that went into developing a rigorous evidence base to be able to justify using this new therapy. And these are some of the results. The first manuscript that was published, this recapitulated prospectively the natural history that Dr. Braunwald talked about, except in these patients, over 50% of the untreated inoperable patients had died by a year. We've now followed these out to 3 years, and it's over 80%. There was an absolute reduction in mortality of 20%, which means that in the first year, it only took 5 patients to save a life with this new therapy in the inoperable cohort. So we concluded in that manuscript that this should be the new standard of care for patients with aortic stenosis who are not suitable candidates for surgery. The second arm was against surgery, and these were some of the best surgeons in the United States. And they had very, very good surgical mortality despite the high-risk status of the patients. And we were surprised that the results, in fact, in the beginning looked to be even a little better than surgery, but equalized by 12 months. We followed these patients out to 3 years, and these curves are superimposable. There are other reasons why I might argue that this technique might be preferable in these elderly, high-risk patients, but we concluded that this could be an alternative and should be explained to patients as a potential alternative if they are at high risk for surgery in this cohort. And what we've learned through these studies, and many, many more studies done outside the United States and other locations, was if we look at the continuum of risk as operable patients, frankly, there are some patients that are too sick to be treated. They fall into the category of what we call futility, and you have to have the discipline to be able to decide not to treat some patients. There are patients who are at extreme risk, the so-called inoperable patients, where this new therapy is preferred, we believe. There is the high-risk group, where I think either surgery or TAVR would be appropriate, although I can have my bias and say that I think a lesser invasive technique may be better in many of these patients. Then there are the low-risk patients, which are 2/3 of the patients who have aortic valve surgery. They should not be treated categorically, except under very unusual circumstances with this new technique. And there is true equipoise. In the middle, these so-called intermediate-risk patients, and we have 2 ongoing randomized trials that will randomize a total of 4,500 patients, surgery versus TAVR in intermediate risk, to decide whether or not there will be benefits of this therapy or not, to help us to make a decision about applying this. We also have developed a national database, again, consistent with the Grundzig principles of trying to look at the data, and now every patient that has this procedure in the United States has to be analyzed in a way that is a national registry, which is linked to reimbursement. So if you want to be reimbursed, you have to fill out a 7-page form on every patient. And I think this is a good thing because it forces oversight. It forces the kind of accountability that's necessary to make sure that these new therapies are optimally utilized in the right patients. And of course, as we said, technology is exploding. There are many new devices. Some will be better, some may not. But I do think this new technique does fulfill Grundzig's dream because there has been a favorable balance of safety and efficacy. The treatment focuses on the most appropriate high-risk patients. We have demonstrated that we can carefully generalize this to the interventional community. It's based on rigorous evidence-based medicine clinical studies. It truly is innovative technology. It emphasizes advanced imaging and a well-characterized treatment milieu. and it's a multidisciplinary collaboration. You cannot do these procedures without having an effective heart valve team. So final thoughts. Well, it's been 35 years since Andreas put a balloon in an LAD, and I think that this subspecialty has grown and evolved, and it's had certainly cycles where I'm proud and less proud of some of the accomplishments. But I think it's also acquired a heritage. So we do believe that less invasive remote treatment using catheter-based techniques can have great value for patients and for the healthcare system in general. And this generally means non-surgical whenever possible, but whenever possible and appropriate. Yes, we are technology addicts, and that resonates with the community of Israel, the startup nation. So we like new gizmos, which can shorten procedures, improve outcomes, and expand treatment indications. We're very passionate about experimental and clinical research and evidence-based medicine. It's fundamental to every important therapy change and to the interventional device development process. We rely heavily on adjunctive imaging. It's a very visual subspecialty. We're passionate about the interface of clinical medicine and the rapid communication of ideas. There's a vibrant entrepreneurial spirit. Interventionalists are often risk takers. They rapidly embrace new therapies. We strongly support and promote global and multidisciplinary collaborations. So there is this cultural identity, innovation, strong industry partnerships, impatience leading to evolution and forward motion. We have a need to stimulate change and to continually reinvent ourselves in pace with advances in biomedical science and technology. So what would Andreas think of what's become of interventional cardiology? Well, I think that he would be approving of the mandate to generate and utilize evidence-based medicine and clinical decision-making. That will never go away. I think he'd be ecstatic. I think he'd be overwhelmed with the technology explosion that has overcome many of the limitations of the original balloon PTCA procedure. He would be enthralled with the extension of catheter-based treatment to non-vascular disease states, as I've suggested, and we've talked about aortic valve therapy, but we could talk about the future in hypertension, for instance, and renal denervation techniques. I think he would be appalled with the sometimes inappropriate use of devices and concerned about operators who don't practice with the highest standards of quality and ethics. And he'd be distressed by the myriad external, social, economic, and political forces that are interfering with the practice of medicine, and we've certainly seen many of those over the past decade. So to conclude, I think we've celebrated more than 30 years of interventional cardiovascular medicine, and it's been on the shoulders of pioneers like Grunzig that we've witnessed the birth of a subspecialty, and I believe that cardiovascular medicine has been forever transformed and patient outcomes have never been better. Thank you very much.